So I think we are going to make a start. Thank you all for attending. My name is Ben Newton and I lead oncology for GE Healthcare. It's a real pleasure to be here this afternoon. Welcome to everyone here in the room. Welcome to everybody watching virtually. And welcome to those who are actually going to be watching on demand. You missed an opportunity to be here in person. Special welcome to our presenters and guests. Although prostate cancer is the most common cancer in men, and it's the third most prevalent after lung and colorectal cancer from a mortality perspective, and it has this wide variation in terms of detection rates and outcomes related to geographic variance and demographic and also racial, it's widely predicted to be having a declining mortality in the next 10 years. And that declining mortality is really made possible by better detection methodologies, better screening and diagnostic modalities, and indeed better treatment applications as well, ranging from, of course, radiation therapy through to immuno and chemo, anti-hormone therapy, of course, and including radiation therapy and increasingly theranostics. So it's with this in mind and this backdrop of increasing precision and targeting of these therapies that it's a real pleasure to host this panel today. We're going to move through a number of presentations and hopefully we'll aggregate our presenters up here on stage and have the opportunity to take questions both from those online and those in the room around the technologies that are being used and, of course, the outcomes that are being obtained by those technologies. So without further ado, we have in this session Dr. Hanna Falinska from Poland, who's going to first come up and talk to us about the role of MRI and her experience of screening and diagnosis and treatment. Rapidly following that, we'll have Dr. Fajkovic from here at the Medical University of Vienna, who's going to talk about brachytherapy and ultrasound guidance of brachytherapy in early stage prostate cancer. Then Dr. Guido from Erasmus in the Netherlands will share with us experience of this rapidly growing and interesting and highly efficacious approach of using theranostics in late-stage prostate cancer management. And then to complete this story around the end-to-end care of prostate cancer, we have Professor John Kelly, who's going to share with us experience not only of interventional work from a surgical perspective, but also, crucially, the remote monitoring of patients recovering from that surgery and, of course, other forms of treatment. So with that, I'd like to welcome Dr. Falinska, and we'll start with our first talk. Thank you.
Good evening. My name is Hanna Falinska. I work for Afidea Poland, and I'm going to speak about the role of the MRI in prostate cancer treatment and diagnosis, and I'm going to focus mostly on diagnosis. These are my disclosures. A few words about Afidea that I work for. We are present in 15 European countries, and in Poland we have 31 diagnostic imaging centers. And what I observe, each year the number of prostate MRI is rising. Magnetic resonance imaging is currently the main imaging technique for a prostate gland because in a non-invasive way it allows to locate suspicious lesions and assess the risk of clinically significant prostate cancer. So we evaluate the prostate gland in multiparametric protocol where we use T2-weighted images to assess anatomy, diffusion-weighted images to assess cellularity, and dynamic contrast-enhanced imaging to assess vascularity. In 2019, the European Society of Urogenital Radiology and the American College of Radiology approved and published the PIRATS 2.1 criteria, which I'm going to use as a guide for this lecture. So, what are the PIRATS 2.1 goals? First, establish minimum acceptable technical parameters. Both 1.5 Tesla and 3 Tesla can provide relevant and diagnostic images, but we have to follow the technical specifications. Because image quality is the key. Only if all multiparametric MRI sequences are of optimal quality, we can be sure that we found all significant lesions and that we didn't miss any. So here I've got the patient who came to our center with previous outside study with quite good quality, but there were some doubts about the lesion in the left lobe. Thank you. In the left lobe. And of course, the improved signal-to-noise ratio means greater diagnostic confidence. Why am I speaking about this? Because in my center, we use 1.5 Tesla vendor with a Recon DL, and we can clearly see this is PIRATS 2 lesion. We've got the diagnostic confidence. Of course, there is this time difference, but it was really small. Recon DL is also the algorithm that helps us to achieve sharp images faster. So, reduced scan time means enhanced patient experience and less motion artifacts. Again, image quality is better. Coming back to our PIRATS 2.1 goals is to standardize the terminology and content of reports, which results in providing clear, understandable data for targeted biopsy. Based on histological zones, the sector map was created. And here is the report template that the PIRATS committee advises to use. So this is the structured report that I use in my everyday practice, where all data that should be included are here, including the tables of quantity values and sector maps with lesion location and images with lesion location. And what is very important, we want to assess categories for patient care pathway. So PIRATS is the 5-point scale that we assess the risk of clinically significant prostate cancer presence, which means, what does it mean, clinically significant? This is the cancer that is going to affect the patient's life quality or even cause death. So PIRATS 1 means that this risk is very low, and PIRATS 5 means that it is very high. The diffusion-weighted images score is the dominant factor determining the PIRATS category assessment in peripheral zone. So here on these images on the top, we can clearly see there are no focal lesions. And the same for transition zone is T2 weighted image. So here we can see no focal lesions, and here we can find atypical PPH findings. So this is a negative MRI, which means that no immediate biopsy is needed, because multiparametric MRI is highly reliable to exclude clinically significant prostate cancer. And the opposite situation in the top images, we can see clearly a focal lesion and in the peripheral zone. And in the bottom images, we can see the lesion in the transition zone, which means this is the positive MRI. What does it mean for us? When we consider the patient that is at clinical risk of prostate MRI, for large PIRADS 4 and PIRADS 5 lesions, we should perform targeted biopsy, and for PIRADS 3 and small PIRADS 4, systemic and targeted biopsy. And we have to remember about the false positive lesions. That's why biopsy is always needed. Of course, the committee wants to educate radiologists, it's obvious, and also to improve interdisciplinary communication. So here is the patient, 65 years old. Digital rectum examination was suspicious, PSA was normal. These are his diffusion-weighted image and ADC map. We can see no focal lesions in the peripheral zone. We can have some doubts about this right lobe, but this is the transition zone, so we have to check the T2 weighted images, and this is just BPH, atypical BPH nodules, so it's PIRADS 2. Patient underwent systemic biopsy and it was negative. Another patient, 76 years old, PSA was 5.67, and here we clearly see the lesion. It's in transitional zone, so we have to check how does it look on T2 weighted images, and we can see it again. It's bigger than 15 millimeters, so it's PIRADS 5 lesion. Patient had fusion targeted biopsy, and it occurred to be adenocarcinoma, Gleason score 7, 4+3. And last but not least, in December, in official journal of the European Union, the Council recommendation occurred to further develop of cancer screening programs and to do the possible extension of organized screening programs to additional types of cancers, namely lung, prostate, and gastric cancer. And for prostate cancer, on the basis of PSA antigen testing for men, in combination with additional resonance imaging scanning as a follow-up test. Thank you for your attention.
Thanks, Dr. Falinska. Please come and take a seat. So next, we have Dr. Vajskovic, who will talk to us a little bit about image guidance of low-dose rate brachytherapy.
Thank you, Ben. Ladies and gentlemen, I'm very glad to be here today. I'm a little bit emotional about this Congress because I'm a urologist and I just have some good memories when I'm thinking back of my further ECRs. May I ask you a question first? Are you all radiologists except Professor Kelly, who I know? All radiologists? Yeah. Any urologist here or oncologist? No? Okay. I should talk today about the brachytherapy. I also used to do that by myself at my early age when I was young resident at the Donau Hospital in Vienna. And at that moment, I didn't have a clue about the prostate. I just did what somebody told me to do. Nowadays, I have to give a talk for a GE about brachytherapy, and my point of view changed regarding the brachytherapy. I don't want to say it went negative, but I just, for myself, because we have a really robust body of evidence for brachytherapy, because we performed that between 20 and 30 years, I would just say a highly selected patient collective would be really good in a brachytherapy, and I will try to say that in those slides. Slides are from the company, but I will talk independent from that, what you see. These are my disclosures or disclosures from the company, and this is the first one, just to remember you what it is. Basically, we heard from Hannah, we can make a visualization of the prostate cancer nowadays. I'm coming from when I start learning about prostate, from the days when we were not able to do that. That's why urologists, clinicians, started to do saturation biopsies, 30 biopsies, 40 biopsies, 20 biopsies, 8 biopsies. Nobody knew how to do it right, because when we put the ultrasound in a patient, we just see what is left, what is right, what is up, what is down. No clue about it, where the lesion could be you want to face. Another additional help was a PSA. PSA is a marker, I agree, it's a tumor marker, agree too, but it is not a tumor-specific marker. This is an organ-specific marker. That means if you get a prostatitis, if you have a large prostate, if you have a Peyronie's 2, as you said, you could still have a PSA of 20. It doesn't help you. After you show us that you can make a visualization of the tumor, starting using an MRI, 1.5 and 3 Tesla, multiparametric, we learned a lot. We learned really a lot. And if I will tell you now, just to see the text I'm showing you on my slide, yeah, we have a low dose and a high dose brachytherapy. And we should treat prostate when we put the seeds, iodine, palladium, or cesium, into the prostate. We do a local radiation, and you would ask yourself, why? To kill the cancer. But why in all the lobes? If you can show me now, as you said, that I have a 5 millimeter lesion in a transitional zone, why should I put the seeds in the left on the right lobe? That's what we did. We will not do that anymore. But still, if we go to our highly selected patients, we will have a patient who has a multicentric T2, T3 tumor, which is localized. And this kind of therapy could be ideal for that kind of patient, just to make a little bit more of that, what is making the problems in my head facing this brachytherapy is, you heard about a HIFU, you know what it is, you maybe use it. I know in London it's a lot, we do it also in Vienna. HIFU is basically, as a brachytherapy, you will do some local therapy of the prostate cancer after radiologists are telling us where the cancer is. Put the ultrasound sound on the tumor and just burn it locally. But what should I do if I have a multicentric tumor? I cannot burn all the prostate. What should I do if the tumor is close to a sphincter? I will do incontinence. That's why all those new technologies are not solving the problem, are also just taught for a high selected patient collective, and same with the brachytherapy. Why to choose a brachytherapy? As I already mentioned, a huge body of evidence we have regarding brachytherapy, and we know it works. But don't forget this one. I'm ashamed of that, but I did it. At my beginnings, we operate sometimes on high-grade pin prostate cancer. Nowadays, we know that is nothing. I operate by myself a lot of patients with a Gleason 6 tumor. Nowadays, we know Gleason 6 tumor cannot do metastasis. If you have a tumor which cannot metastasize, cannot kill you, why should you operate on it? But I need you to tell me for sure that is a Gleason 6. Do you think that you would be able anytime to tell me a Gleason score of a tumor on an imaging? I'm not sure. We can fight afterward, but I'm really not sure that I can say to a patient afterward, look, radiologist told me you have a low-risk, low-grade Gleason 6 tumor, ISUP2 or whatever. This tumor is not high risk. I think for that, we will always need tissue. That's what I'm thinking. And now the question is, if you see the numbers, for low and intermediate risk, you have 85 to 95 PSA control. What does it mean, PSA control? Biochemical recurrence, what we are calling in a urology, if a patient after a surgery, after brachytherapy, after any kind of therapy, his PSA start to increase, we are saying patient is in a biochemical recurrence. And then what do you think we perform? Some imaging. And I learned from my friends in my hospital, radiologists, don't go too far. And now we are facing a second problem. The data I have in imaging are MRI and CTs. You told me for years, there's nothing, lymph nodes, no bone metastasis, nothing. And then you start using PSMA PET. And now, when I'm on 0.4 to 0.8, I have good chance already to make a visualization of small lesions I would never see in a CT. What should I do with that patient? All my knowledge, which kind of the therapy should I give to a patient, I have from CTs and MRIs, and I'm facing the tumor cells now in PET, MRI or CT. It is not the same. And the same problem we have with the brachytherapy, because the data showing you for 30 years that the low-risk tumor can be really good cured are the data actually, from my point of view, which should have an active surveillance. They don't need nothing. These are Gleason 6. Still, as I told you, there is a patient collective, and I want to focus on that. We should not give up the brachytherapy, because few of the patients, selected patients, will really have a benefit if they get a treatment of the old prostate, and this is not a surgery. There are a lot of reasons not to get a surgery from urologist in a prostate. First of all, first tumor worldwide, which patient advocacy showed and make a pressure on us to say, okay guys, you have a perfect oncological control of the tumor in a prostate, but you forgot about the quality of life, with really, really high numbers of incontinence and really high numbers of impotence. I consider my department as a high-quality department in surgery, in oncological surgery. We do have a Da Vinci robotic system, and we use that. I do that by myself. And still, if I'm honest, and I'm trying to be honest in my life as much as I can, about 50% of the patients I'm performing nerve-sparing method of the prostatectomy. That means I'm telling to patients, I will leave your nerves to be able to have erection. About 50% have an erectile dysfunction, are not potent afterward. That means a half of my patients I'm not doing good enough. It's hard, half, every second. And the patients are telling me, and us, there is a Europa Hiomo, that is a patient advocacy organization. I talked by chance today with one of those guys from Belgium, telling me the same. The patients are not allowed, they don't want anymore as the years before, just the control of the tumor and survival and no biochemical recurrence. They want quality of life, especially men in prostate, especially when they're young. If you do brachytherapy, the chance is quite high that you will keep your potency and that you will not be incontinent. Is very high. But still, I would ask you, if you take that too, but oncological control is not good enough, to do surgery after the brachytherapy is not funny. It's really not funny. Even a TUR, if you choose a prostate, which would be maybe good to treat with the brachytherapy, but the patient has a BPH. And I did that cases few times, the resection of the prostate, TUR, transurethral resection of the prostate after the brachytherapy. You're just cutting, and every single cut or every second cut has a contact with the seed, with the metal, and it's blowing away, and you're nerved, and you need 3 hours, and it's bleeding, and you don't see anything, and it's frustrating. Don't do brachytherapy in BPH. Avoid that. Last but not least, I have 2 more slides, then I'll stop. Just to show you, this is a system I use. I use it also in my private practice, not for a brachytherapy, just for ultrasound of the patients for the normal controls. This is a BK, this is a portfolio of General Electrics. I would say the greatest ultrasound for urologists in a moment. B-plane transducer, you will need it from transrectal ultrasound diagnostic. Stepper and the grid to be able and ensure to put the needles at exactly that spot you want to put it. Stabilize all that to really be sure that especially if you do a fusion and make a visualization through fusion of the pictures, you will put the needle exactly at the spot you want to put. This is how you should do it. And the software. All these things I just can recommend. But you should not forget that we need a partnership. Urologists need not only a perfect radiologist, and vice versa. You would also need a urologist to understand and to be able to do everything right with a patient like that. My last slide, showing that just as a schema. Yellow, I see me as a yellow in this world, ECR. Pre-procedure preparation. You need a patient. You have to be sure, is it really all correct? You should be sure that inboard biopsy, which I would say it's a natural reflex for a radiologist to see a lesion, to put a needle in the lesion and say, I did a biopsy, 1 biopsy or 2 biopsies. It's something natural for you. For me, it's not. I'm coming from the era where we did it blind, and now I know that in 15 to 20% of the patients, if I do additional systematic biopsy, I will find tumors. The question is, are those tumors significant or not? We can discuss this afterward, but you need a urologist who will help you understand the clinical part. And the urologist needs you even more to see, to be able to see and not to stay in last 20 years like blind idiot, just seeing an organ but not seeing a lesion. We have to help each other. Yellow, clinic. After that, it's easy anesthesia you need, placement of needles I show you, imaging structures with the system I can just recommend, treatment planning, treatment delivery. After that, patient recovery, again urologist, because you can face the problems, doesn't matter which method you're using. I hope I could give you in this 10, 12 minutes my thoughts, not only about the brachytherapy, about the patient selection, about the cooperation, about the friendship between colleagues in the hospital, about patient safety, needs. We would need, I think, 2 hours just to discuss a little bit of prostate together, radiologist and urologist, but at this moment I have to stop. I think Ben will kill me if I keep talking. Thank you very much. I'm really glad to have you here. Danke, dass du da bist, Baby.
Thanks, Aaron. Come and have a seat. Thanks. Fantastic. So we're going to move through the care pathway a little bit more in the next talk. And Dr. Guido, who's going to come to us from the Netherlands, is going to talk to us about the role of theranostics, particularly with respect to the role of lutetium PSMA in advanced disease. So thank you very much.
Thank you for the introduction. My name is Guido de Lucenet. Our disclosure is that the contribution is made to my employer. So theranostics or theragnostics is a combining therapy and diagnostics to precisely find and kill disease foci and spare healthy tissue. And so this concept of a magical bullet was already awarded the first Nobel Prize in Physiology back in 1901. About 40 years later, radioiodine was invented to treat thyroid disease, and another 40 years later, success was made in treating neuroendocrine tumors by targeting the somatostatin receptor. And now there's another success story in targeting PSMA for treating prostate cancer. But you need a good radioligand for the therapy and the diagnosis. And there's very many isotopes. Here are just a few, but you have to decide whether you want to perform PET or SPECT or give beta particles or alpha particle emitters. And those have to be bound in a very good chelating agent. Similarly, as with the gadolinium for MRI, you have a need for a good chelator. You need a good linker, small, strong, and it has to resist, for example, enzymatic degradation. And you have to know that there's several PSMA ligands out there. So the one approved right now is 617, but in Rotterdam we use the PSMA INT. And PSMA receptor expression is very important, and not all prostate cancer has PSMA expression. But there is a correlation between aggressiveness and the PSMA expression. But PSMA is also expressed in some non-prostate cancer, and also even in benign tissue. So you need hybrid imaging. So on your PET, you can see the PSMA expression, but you have to know if it's in concordance with other imaging, either PET-CT, PET-MRI, or even sometimes FDG PET. You want to know if it's true positive or false positive, and it could be benign. Is the ganglion, is it uptake in a hemangioma or what have you, or is it non-prostate, breast, lung, thyroid cancer? Or is it a PSMA negative lesion? So here's an example. This patient was not fit for PSMA therapy. You see a lot of uptake in the bone, but you might consider, is it really a lot of uptake? Because it's hardly higher than the physiological uptake in the liver. But look at this lymph node. As a radiologist, I don't know who would report this and say maybe it's a reactive lymph node, but this is a true metastatic lymph node. There were a bit more lymph nodes as well. And this is PSMA negative. So that's one reason why the patient is not fit. And also, if you look at the CT, you see quite a bit of sclerosis. So this could also be scarring from prior treatments. So sometimes you can use FDG PET-CT. If there's a lot of uptake, you think there's going to be residual tumor with less PSMA expression, or it could just be scarring. Another form of hybrid imaging is PET MRI. I'm a really fan of PET MRI. There are new silicon photomultipliers that are MRI compatible, so you can have it integrated in one system, so you can have simultaneous measurement of the PET and your MRI signal. So you can have your total body diffusion and your total body PET as a comparison, and you can have liver-specific sequences, for example. And so you can decide that this is a truly PSMA-positive liver metastasis, and this is just a benign liver lesion without any uptake. Of course, there's very clear bone metastasis with the bone edema and a lot of uptake. Here's some uptake in the kidney, but also it helps you have more confidence in calling this a true metastasis and not just some aspecific uptake or noise, because it's also visible on MRI and on the diffusion. So diagnostics can help improve prostate cancer management. Here's one patient we have, 76 years old with prostate cancer, and the patient has had very many therapies already, including experimental therapies, but then again there's a steep rise in PSA, and the life expectancy was considered to be about 6 months. And now, as a last resort, the patient entered our phase 1 dose escalation trial and received 2 cycles of actinium PSMA, and the patient is still alive. There was some improvement in quality of life as well, but the patient did have a dry mouth. And if you look at the PET prior to the therapy and post-therapy, there is less uptake in the salivary glands, and that explains the dry mouth. But there's a lot of reduction in tumor load, particularly a lot of lymph node metastasis in the abdomen, and also a decline in the PSA. So theranostics can help improve prostate cancer management. Like we said already earlier, there's a lot of prostate cancer out there, and most have a very good 5-year overall survival, but there is a group that become castration resistant and may develop metastases over the years, and some will not really respond to all the available local or additional therapies. And for those patients that are still progressive despite therapies, the lutetium PSMA is now approved, but there's still a lot of future developments, such as the actinium PSMA example I showed. There also has to be a very good patient selection. So the patient has to be progressive, but also has to be self-reliant and needs a good, or at least a life expectancy of at least 3 months. But also you need a sufficient renal function and hematological parameters. And for example, you have to have had less than 25% bone marrow radiation, because there is about 10% chance of grade 3 to 4 adverse events, ranging from fatigue, a dry mouth, or nausea or pain, but also anemia or thrombocytopenia or leukopenia. And as a radiologist, it's also very important if you help the nuclear medicine physician, because you want to call if there's still a large prostate with a tumor inside it, because that could swell up. And you don't want the patient coming to the emergency room with the acute bladder retention. This patient needs a bladder catheter during the treatment. And also, if there's ingrowth in the spinal canal, you want to call that, and the patient needs steroids to prevent spinal cord compression. And you have to be sure that you can give good instructions regarding the radiation protection issues. And you want to be sure that there's PSMA expression. So the lutetium PSMA has been improved now because it was really proven to improve outcome. There's a vision trial in the New England Journal, and also the therapy trial in the Lancet, but there is still room for improvement. One slide on what radionuclides do, because they kill the tumor primarily by damaging the DNA. And there's a difference. I will not talk about the Auger electrons, but beta radiation and alpha radiation are quite different. And also there's a difference amongst the particles themselves. But in general, beta particles have a longer range of several millimeters, and they cause less complex DNA damage, a lot of single-strand breaks, whereas the alpha radiation has a much shorter range, but has very complex damage, double-strand DNA breaks, and really kills the cell. So you have to consider the absorbed radiation dose and also the biologic half-life and the radiobiology, such as the cellular DNA repair mechanisms. And of course, you want to still consider the patient. And one last slide on dosimetry, because it's mandatory. It is to improve risk versus benefit. Ideally, you would want to measure each patient multiple times, whole body, after each treatment, but that's just not feasible. So right now, the current practice is that we all give a fixed dose of 7.4 gigabecquerels in multiple cycles, but that leaves us with a variation in absorbed dose and response relation. And yeah, some tumors get somewhere between 1 or 8 grays per gigabecquerel, and you are ending up with some non-responders. But we do know with the 7.4 gigabecquerels that generally the critical organs are safe. But in the future, we would hope to do patient-specific dosimetry, and hopefully with upcoming much better imaging systems, such as full-ring SPECT-CT, which has much better images. So here's a SPECT image of like the salivary glands, which are very easy to detect, and also the damage you did after your actinium treatment, versus planar imaging, on which dosimetry is going to be very difficult. Now, if you add artificial intelligence and pharmacokinetic modeling, probably dosimetry is going to improve over the years. So as a take-home, the lutetium PSMA is approved, effective for metastatic prostate cancer, and we are very good. I think our strength is that we can really have a good patient selection, and we decide not to give therapy when there's no chance of success. There are a lot of potential improvements that I'm not going to talk about right now, but we also have to consider the limited world supply at the moment in the radioisotopes. And there's a lot of improvement in imaging nowadays with the silicon photomultipliers, where you have much better PET detection and integration with PET MRI. And also there's now real new advances in SPECT-CT. And hopefully we can improve dosimetry and get a better understanding with dose response relation. And with all this together, I think even in the future, we can be even better in helping to improve prostate cancer management. Thank you.
Thank you, Guido. Please come and take a seat. So last but by no means least, we have Professor John Kelly from UCLH, who's also the lead urologist there and head of the London Cancer Clinic. And John's going to talk to us about surgical intervention and remote monitoring of patients and their recovery and deterioration after treatment. So thanks, John.
Thank you, Ben. Good afternoon, everybody. My name's John Kelly. I'm a urologist, and I work at University College Hospital in London. I also work at University College London within the Department of Digital Innovation, and at the WICE, that's the Wellcome Centre for Surgical Research. I'm going to talk about a concept that is evolving, an application where we look at artificial intelligence, or maybe better, talk to it as machine learning, and how we look at different data streams that exist in this room today, imaging data streams, pathology data streams, surgical outcomes data, to improve or answer questions to improve the care that we can deliver to our patients. In truth, it's an evolution that has resulted in a spin-out company from University College London called Athera Health. And I'm going to start the journey with what might be a remote patient monitoring complete solution. The concept that a patient leaves hospital and they're monitored with a Internet of Things ready device or a bespoke device, and they see a dashboard about themselves, their recovery, the context of how they're recovering, and that's fed back to their medical team. First of all, my disclosures, I have received financial support from GE Healthcare. And as I mentioned, I talked about a complete solution, but in actual fact, the work that we have done has informed us that if we look at remote patient monitoring data, biometric signals alone, it does by no means give us the complete picture of a patient. To have the deep, meaningful insights, it's important to combine data sets to look at different ways of assessing a patient through, as I mentioned, imaging or pathology. And to do that, the data has to be orchestrated. So we know that we sit in an NDT and we can communicate effectively with each other. But to do that with our data streams, there has to be a system that's stable, that will aggregate data, that will orchestrate it, and can deploy the results. And that's why we're working on GE's system called Edison, which many of you may know about. I'm going to inform how we started. So we performed a study where we were looking at recovery of patients after surgery. And we were looking at two different types of surgery, robotic versus open, but we measured recovery using a remote patient monitoring solution. And we asked the question, can we predict patients who are going to be readmitted to hospital after surgery? Readmission is a key metric. It's not good if you have an unplanned readmission to hospital. And there are systems that do that. They're based on risk assessment scores or nomogram. In this receiver operating curve, this is a standard risk assessment tool called POSSUM, which we've used. And when we added in activity data, we see that we increase the area under the curve. This is a very crude assessment. Simply by adding in step counts of patients, we see that we can more accurately predict patients who will be readmitted to hospital. Now, that is a shift from a risk assessment score or a nomogram to a machine learning algorithm. And you can see from the number of variables that go into that model, it would be impossible for us in our day-to-day life as healthcare providers to use that amount of information to understand whether a patient's going to be readmitted or not. But it tells us that we can assess these different types of information and potentially deploy within our healthcare settings an artificial intelligence type assessment of our patients. So I'm going to talk about how and some examples of how we've used this in our current work in prostate cancer. And the most important thing for us is to make this a reality. It's not about the future. This is about what we're doing in the now. And for that, we need a reliable intelligence platform. And that's what we're using with GE. We're doing some deep dive analytics. But the first thing we did was we asked a very simple question. Can we take a man after radical prostatectomy and predict early in the recovery whether he will be continent at 12 months? To do that, we took one of our training data sets of around 2,000 patients, and we pulled in electronic healthcare data, such as BMI, comorbidities, age. We pulled in operative data that is stored in our EHR. We pulled in our remote patient monitoring data, such as activity, pad use, and we pulled in imaging data, most notably the maximal urethral length. And with that data streaming onto our server, we can, with high accuracy, inform a patient whether they will be continent or incontinent at 12 months. This is an example of the readout. In this example, we can say a probability of around 75% that this patient will be incontinent, and the reason is weighted. It's a combination of maximal urethral length, the type of leakage they're having, their severity, and their pads. Their age is improving their odds, as is their clinical T-stage. Not only can we predict that this patient will be incontinent, but we can tell the patient how many pads they're going to be wearing at 12 months. By inference, we can then signpost that patient earlier to better physio, perhaps a sling operation, perhaps an artificial urinary sphincter. But we can only do that if it's possible to automate this and it's possible to orchestrate this and deploy on a platform. So we now auto-segment the urethra. We've done this through a supervised learning process using publicly available data sets. And that data streams onto the platform, the Edison platform, with the different types of data sets to give a readout. Another example, well, this is about decision support. This is about being able to say to a patient, at 3 months, we think there's a better way forward for you. I am going to finish with another example where we said, if we can do that, and we can do that very simply with complex data, Let's really stress test and look to what the future might bring. So we're now looking at the relation between performance status, nutrition, the immune phenotype, and outcomes for men with advanced prostate cancer receiving chemotherapy. So when we think about prostate cancer and exercise, we know that therapy has an effect, cancer has an effect, and exercise has an effect. Exercise impacts not only on the inflammatory process, our circulating cytokines and chemokines, neovascularization, telomere length, and it affects our genomic profiling. It can alter methylation status of patients. And we propose that there is an effect that exists that might be negative in terms of cancer survival between the immune phenotype, exercise, and a nutritional state. And so we look to other systems to ask, does this bear out? And if we look at breast cancer, there are studies, for example, the Diet, Exercise, and Lifestyle Cancer Program, which show a profound relation between exercise and outcome. So for female patients with breast cancer who have low activity, compared to female patients who have moderate or high activity, the cancer survival outcomes are very different. And we have opened a study whereby we are pulling in data. So we're pulling in microbiome data, and that's a picture almost of our immune phenotype. We're pulling in EMR data. We're pulling in remote patient monitoring in terms of biometrics, and we're reading subtleties that would signify early sarcopenia by pulling in imaging. This is all aggregated on the Edison platform. It's curated on which we can do deep learning, deep dive machine learning algorithms. If I were thinking about this 10 years ago, this study would have firmly sat in the realms of research. It would not have made the light of day as a clinical application. But with processes that are integrated with our EMRs, such as Edison, this study can switch from something that is hypothesis generating to hypothesis testing to clinical application. It's almost as if we're standing on a time that's going to change for us, which is in one way machine learning, but in another way, it's a here and now solution for our patients. I'm going to finish just to mention, yes, we have spun out a company. It's called TheraHealth, our remote patient monitoring platform. We use and give out to anyone that wants to use it. It's available for anyone who wants to apply this type of technology to answer questions about their patients with prostate or other cancers. I'll stop there. Thank you very much.
Thank you, John. Come and take a seat. We're opening now for one or two questions. If there are questions from the audience, please come forward and take a microphone. And equally online, you're welcome to submit some questions as well. One just here, actually, Dr. Falinska. How long does it take for you to carry out each scan? And then what's your throughput using the technology you described?
It's now about 25 to 30 minutes to have a prostate MRI.
And the throughput for each day?
How many?
Yes, sorry, patient throughput.
Okay, so the prostate patients each day we have, it's about 5 to 10.
Okay.
Because we do a lot of other examinations.
Right. And there's agreement, I think, in that as well.
It is.
Dr. Fajkovic, in terms of the use of brachytherapy in localized disease, have we got the guidelines correct with respect to its use in the context of external beam radiation therapy and the stage of this?
If you use we have better results with external beam therapy.
Yeah.
Our guidelines showing that. There are some studies from Laurie Klotz from Canada showing the differences. Astro is having a guideline on that. EAU is moving a little bit away from that. If you want to have my personal opinion, I'm seeing radiation therapy really basically as adjuvant therapy, not the primary one.
Yeah.
Radiotherapists hate me for that, but I really think it's like that. I think if you do a correct surgery, if you're able to do it, there is always a room here for adjuvant radiotherapy. But if you do a primary radiotherapy, I don't know if Dr. Keller would know, but to perform adjuvant surgery, it's much more complicated than do adjuvant radiation. And when I was talking about the brachytherapy and the primary radiation therapy, I think for a really highly selected patient collective, good. If you should choose between brachy and external beam, I'm not the expert to say now what should be better, but if you would ask me, and I was talking today about brachy, it would be unnatural that I say don't do brachytherapy. But as I said, problems with TURs afterward, problems with this and that, concurrence with the HIFU, there is a really small room for a brachy in the future, I think.
Yeah, I mean, there's two issues. One, the surgery for salvage, and we've published well on the difficulty for salvage. So salvage after brachytherapy is a nightmare. Salvage after HIFU is similar. And salvage after primary radiotherapy doesn't have the outcomes that we would expect it to have. So I think the best option is the patient choosing the right option first. Clearly, there's a whole variety of treatment modalities that we can apply. And there are a large number of patients who may or may not need treatment. So I always start a conversation with my patients. Only about 30% of patients with prostate cancer actually need treatment. And the difficulty is just, and we're much better at it now than before, but the difficulty is just finding those patients. And I think MRI has taken us a long way forwards in being able to do that.
Agree. Actually, it's not, that's what we did before MRI. I don't want to talk, I don't want to think about that period, actually, but I'm facing the truth now. Yeah, and radiology helped us with that. So there's no doubt in that.
And Dr. Falinska, that's something which we were talking about earlier. In terms of clinically relevant disease, actually knowing when not to intervene.
Yes, when we should stop, or just to take in observation, or even if it's Gleason 6 cancer, so do active surveillance.
Yeah. Question online for Dr. Guido here is, do you expect lutetium and actinium PSMA to be used side by side? Or will actinium kind of overtake lutetium? And I guess that's notwithstanding the supply chain issues with lutetium.
That's a very good question. I think the microphone was on. Thank you. That's a good question. World supply is a big problem. Actinium, there's only 4 locations worldwide right now where you can get it, and there's annually about 1,000 patient doses. So right now, actinium is not going to take over. Yeah. I think side by side could be good options. There's been publications on this, and we also have one of our patients in the phase 1 trial is now who had 2 actinium cycles because that was a trial. Good response, but not cured, is going to start with lutetium PSMA now. And you have the range, you have the short range and the longer range. If you have a very heterogeneous tumor with the expression, then alpha emitters may not get everything. So you may need longer range particles. And then you have lutetium, which has a relatively nice range, but sometimes, like in livers, we treat with yttrium for heterogeneous tumors. So there's a lot of things going on there as well.
And actually, just to follow up here, in terms of dosimetry, do you envision dosimetry to be used to find the therapy schedule as much as the therapy dose in future?
Well, the therapy schedule right now, maybe what we do now and what's published, if you don't think you have enough dose, you can just add an extra cycle. But you know, right now we have the levels for the critical organs, but if you maybe like we do in thyroid cancer treatment, we do really in some metastasized thyroid cancers, we do a very good dosimetry and we give the maximum dose we can get. And also in liver yttrium therapy, we do the same thing. Yeah. We can see how high can I go as long as I don't kill the liver or other vital organs.
Got it.
And so you have very many small metastases with prostate cancer, and if you get only a few gray in there, it's not going to cure it.
And so this is one for me, actually. I'm curious about the lines between diagnosis and treatment and monitoring are getting very blurred, it seems, particularly from a fusion perspective, from an ultrasound and from an MR and a PET perspective. So maybe Harun and Hannah, questions to you. What circumstances do you see that fusion being used right now? And then how do you see that evolving, I think, with this sort of blurring of lines between the need to get greater precision?
Ben, best question I heard today in all Congress. I will give you clear data. I have my own data, and those data are correlating with international data. When we used to perform a biopsy with the ultrasound before fusion, I had, and this in international literature, Professor Kelly will know the same, I think he published the same, was about 30% upstaging in the prostatectomy tissue. If you're comparing that to a blind, that means ultrasound-guided biopsy. Agree. 25 to 30% upstaging. That means bad. Every third patient, you maybe didn't take lymph nodes, we could discuss that, but you make the decision according to failure data.
Yeah.
Because you just took some tissue from somewhere, somehow, left, right, as I told today, left, right, up, down.
Right.
And then you told us you can make a visualization of the tumor and of the lesions. And we start doing, at my institution, with your system, with BK system, we're doing that since 5-6 years. And we start doing exclusively only fusion biopsy. No systematic biopsy with a transrectal ultrasound. And take a look at the same data, same team, same machines, just another software because we're doing a Euronav. And came to 5 to 10% upstaging in the final pathology. It means 25, not 25, actually, from 30 to 5 is 70, hazard ratio is extremely high. That means we just starting using fusion biopsy, starting making decisions for a cancer according to a right information. That's what we did till now, 30% wrong. And now we are 5 to 10. That means there is a way still. I'm not sure that radiologists knows everything, because still 5 to 10% upstaging, you should tell us better. But
false positive and false negative MRIs also?
No, not only. We have upstaging, and upstaging is something which I should consider as a problem as a urologist. If you tell me it's a Gleason 7A, is it 3 plus 4, I would never come to idea to perform a lymphadenectomy. But if you tell me it's a 7B, patient is young, PSA is 9.8, not 10, still intermediate, I would still tell to him, if I would be you, I would let me take out my lymph nodes, pelvic one. Maybe you disagree, but this is basically, that's what we are taking. First, oncological control. Afterward, don't take a risk of the physiologically possible complications of the patient. But first, cure. And I can only cure if you tell me what it is. You did it better because we were at 30, we are now at 5 to 10, but we has to have 0. That's what I think we should do.
Yeah, so I think we all want to be there. We do a diagnostic MRI, and it's reported in such a way. And then we sit with our radiologists once a week to plan the following week's surgery. And that's a planning meeting. So we have MRI, we have biopsy result, and we then create a surgical map. We decide whether we're going to do frozen section on the nodes, on the nerves. We decide if we're going to do a node dissection, and we decide whether we're going to do Retzius or a standard radical prostatectomy. And we report our results every quarter, so about 250 cases every quarter are reported to our surgeons. And we are still striving to bring those rates down.
Right.
It's quite interesting that. I still think there's quite some way with imaging that we need to get improved in terms of understanding capsular penetration, overcalling T3, maybe early seminal vesicle. So there's some way to go, but I agree, MRI has been a game changer for us for sure.
Yeah, absolutely. And maybe before everybody starts to leave, John, in terms of this point about blurring the lines. I think the studies that you presented, where you're looking at outcomes almost in real time and their relationship with those input variables, you're kind of doing that in real time. And I think with the remote monitoring piece, actually, it will come to fruition in a sense, that whole connected care piece from the patient right the way through to their outcomes.
Yeah, I think the key is real time. I think being able to say we can support decision making in the clinic with data that's available from remote patient monitoring, but also from imaging, from pathology. It's an incredibly powerful tool to be able to say, I think we're doing a slightly different pathway to what we'd set out, and let's change the way that we recover this patient or that patient. That's all achievable. I mean, I think, we know about Chat GPT. We've seen what it's going to do to our lives and how we interact differently with our mobile devices just by having an innovative AI platform. I think the same thing is going to happen with healthcare. I've no doubt about that. There's so much data there. It can only be mined by machine learning, and the outputs from that can almost be activated almost immediately.
Yeah.
It's very exciting.
And if anybody hasn't used ChatGPT, have a play with it afterwards. It's been a pleasure to host this, and thanks to everyone for attending. If you want to know more about connected care, the prostate cancer care pathway specifically, please come to the GE Healthcare booth. Any questions? We'll be around for a few minutes, I think, to take them. But thanks again to our panelists, our presenters. Thanks to you, and also thanks to everybody online, and look forward to speaking to you later. Thanks very much again.